All right, well, welcome everybody to our Coffee and Conversations for June 7th. Good morning, good afternoon, and I think good evening in some places for those of you joining us. Today, we are pleased to welcome Lemlem Beza, who is a lecturer and researcher at Addis Ababa University in Ethiopia. She completed her PhD in nursing in a joint program between Emory University and Addis Ababa University. And she is currently a Fogarty Global Health Fellow under the Vanderbilt, Emory, Cornell, and Duke University Consortium. So it's the VECD Consortium. Lemlem was actually a scholar at the University of Michigan as well. She was part of the University of Michigan African Presidential Scholar Program. And she worked with Dr. Sue-Ann Bell on disaster prevention, preparedness, response, and recovery in 2 public health hospitals in Addis Ababa, Ethiopia. And she's remained a friend of our school and office and has stayed involved in publications and events that we've had. And we're really pleased to welcome her here today to speak about emergency care, pre-hospital and hospital care in Ethiopia, with a focus on the COVID-19 response in low resource settings. So welcome, Lemlem. Thank you so much for joining us.
Thank you so much for nice introduction. So the first slides, of course, about myself. So thank you very much for flattering introduction. Thank you, everybody. And I miss all of you in the School of Nursing. Good morning. And it's a pleasure and honor to give this talk in front of you. So as it has been mentioned earlier, it is coffee and conversation, just to talk about pre-hospital and hospital care in Ethiopia. And so this coffee and conversation is a common practice in Ethiopia. I'm very pleased to talk this kind of, to participate in this kind of conversation. Thank you, Michelle, for inviting me. So we call it in local language, this coffee and conversation, as bunna tattu. Bunna tattu is you see the mothers and the family send their kids to knock the door of the neighbors and to say bunna tattu, and then the people will come, and as you can see in the picture, people will come together and talk. There is no frame for their talk. That talk might be social issue, economical issue, whatever happening new in the neighborhood and things like that. So I will be happy to participate in this very casual and common practice in Ethiopia. So
Lemlem, I don't want to interrupt you, but the slides, we're kind of seeing them all laid out. There we go. Perfect.
Yeah.
Thank you.
So yeah, this is a bunna tattu ceremony in Ethiopia. It is common practice, as I have explained earlier. So my name is Lemlem, and I am from Ethiopia and born and raised in around capital city. I did my BSc degree from Addis Ababa University, the oldest and the largest university, and my master's degree from that. And I am also an alumni at the University of Michigan African Studies Center, and recently completed my PhD degree from joint program between AAU and Emory, and postdoctoral fellow at VECD, as it has been said. So currently, I am a full-time employee at the oldest and biggest university in Ethiopia, Addis Ababa University, and currently working as a unit head of Department of Emergency Medicine and at critical care nursing, emergency and critical care department since 2016 until the present time. And also vice president of Ethiopian Society of Emergency and Critical Care Professional since 2018 until present time. And also I have lots of work as a consultant in Ethiopian Ministry of Health, and working in different quality improvement project protocols and guidelines and the like. And I have lots of community service in this capacity. So my research focuses on, as you can see here, cardiovascular disease emergency, which is the commonest our country, Africa in general, as highly challenged with both communicable and non-communicable disease, double burden. So recent time, the scenario is changed. So communicable disease is declining, like HIV and the diarrheal disease, but communicable disease is skyrocketing, like as you can see here. Cardiovascular disease is increasing. So my research focus is on cardiovascular emergency. So in particular, I am interested in acute coronary syndrome. So my PhD dissertation was on acute coronary syndrome, patients' awareness about the symptom and their treatment-seeking behavior, because it is a time-sensitive issue, and what matters for patient outcome is the golden hour. But in my country, the golden hour has a different scenario or a different meaning. So just to contribute some about treatment-seeking behavior and delay, pre-hospital delay time. So I'm focusing on that. As you can see, the city is very crowded. We don't have that much organized pre-hospital system. So, and people are coming from remote area with backpack carried by a human being and using carts, and also long, very slow bus from rural area. So that's why I'm interested, and my postdoctoral fellowship program is also an extension for this my pre-doctoral degree program. So I'm also focusing on that ACS, which I did a community study in my doctoral fellowship program, postdoctoral fellowship program. So I wish to tell you a little bit about Ethiopia. Ethiopia is the oldest African country and the only independent African country, and the second populous country next to Nigeria. And little information about Ethiopia. It is the only country in the world that uses a 12-hour time. And it is a country that coffee is first discovered, and it is a country that has a 13 years sunshine, and a country that has a long Narva River, and also the country that hosts the hottest habitat in the earth. We call it Dalor. And just to give you health-related information in Ethiopia, as I have mentioned earlier, it is populated the second populous country. Account is estimated to be 120 million people, and majorities are young population. 44% are under 15 years, and 52% are 15 to 65 years, and only 3% of the population aged 65 and above. And when we see the life expectancy, this time in 2021, it increased to 67.44 years. And coming to maternal mortality ratio, it is this time in 2021, 412 per 100,000 live births, maternal mortality ratio. Child mortality rate, 48.7 days per 1,000 live births. Neonatal mortality accounts now 27%, 27 days per 1,000 live births. The Ministry of Health is trying to reduce in the coming few years, especially the maternal mortality, to be 119. There is a projection to reduce at that level. So the cause of maternal mortality in Africa, as well as in Ethiopia, specifically, hemorrhage is the leading cause of mortality, followed by hypertensive disorder, sepsis, and other direct causes like abortion and indirect causes. And a little bit about emergency medicine development in Ethiopia, which is very crucial for COVID-19 response. And so it has a history of a decade. It has been started in 2009. Before 2009, there was no organized emergency service in the country, no trained professional, no triage, no pre-hospital care, no organized disaster response or any public health emergency response in the country. And recently, we have 20 emergency and critical care trained nurses in the country, all over the country, and 110 emergency and critical care physicians, and very few emergency medical technicians and paramedics. So the school was opened in the largest university I showed you where I'm working in AAU. And then this time it is lots of school is opening to train the emergency nurses and physicians. So back to the COVID-19 pandemic response, I'm guessing that Ethiopia can represent the low and middle income country. I'm guessing the response is quite similar. So it has been a major threat to low and middle income country, in particular to our country. The reason why is there is a huge shortage in health infrastructure, human resource, especially that are to be deployed in this pandemic. And I remember the first case in Africa reported was in Egypt, and Ethiopia has reported the first case on March 13, 2020. He was the Japanese guy was in Addis Ababa. So the first case was reported from Addis. Addis Ababa is the capital city of Ethiopia, with the largest city, populated to be 6 million. So the Japanese guy was identified to be positive, and he was in Addis. So it is the first case. It was in March 13. And afterwards, in April 2020, the government at national level launched, which is led by our prime minister, declared a 5 months shutdown or lockdown. But it's still the lockdown allows some economic activity, because it is Ethiopia is there are people, the majority of our population lived with daily laborers, and their economy is depending on with their daily income. So we did a 5 months emergency declaration led by our prime minister, but the lockdown is not like complete like other the developed country did, but there is some sort of restriction. So coming to the total number of COVID cases since today is 475,321 since today, and total days we have is 7,550 total days since the pandemic. So what has been done is, you see, was a challenge for the country like Ethiopia. It was a challenge. As I have mentioned, the first case was identified in Addis Ababa, and where people are living in crowd, where a lots of economic activities is there. So following that, the government did a lots of sorry about that. Sorry. So what has been done to respond or to contain the COVID pandemic in the country is there is international travel restriction, and our airlines reduce the travel by 10%. There's closure of gathering places, avoidance of overcrowding, all the social distancing, the hand washing, and all things were seriously activated, started from the capital and going to the regions, because the first case was in the capital city, Addis Ababa. So it was a challenge because 80% of the population lived in a rural area where there is no active communication system to aware for the rural community. So only those who have the means of communication like television and other communication devices or other media outlets have got the chance to get the information. So anyway, the government tries all the possibilities to reach. So proper use of protection materials, glove, mask, and the like. So even though the scarcity, one of the problem, people try, once the community gets the information, trying their best to have the protection material. The scale up of the test. The testing was also a challenge because the test kit was not available in the first time. So we were sending samples to outside of Ethiopia. That was a challenge. So the government trying with a donation from developed country, scaling up testing was one of the other things done for COVID response. And public awareness, as I've mentioned, and education was a huge challenge for Ethiopian community to reach, especially the rural people. So for this, we thank you for Ethio Telecom. They try to make it the mobile ringings to be a message of COVID-19, like wear mask, test, social distancing, and the like, and also vaccination. Until today, 23 million people have got the full vaccination for COVID-19 in Ethiopia. So what was the challenge? The challenge in Ethiopia for this pandemic is living in a different way. And the living condition, the living style is completely changing. So those restriction modalities is not into the culture of the Ethiopian. So the pandemic meant, you see, the poverty make a deep grab on the poor people. So many people do a choice of like protecting their family from COVID-19 or feeding their family. This was just balancing this was a huge challenge. The other thing is even as I mentioned, the strategies that is declared for the prevention of COVID-19, like social distancing. Ethiopian community is always hug each other. Otherwise, they may consider that it is not greeting. Unless you hug people, you are no more. Unless you climb people, you are no more greeting that guy. They are
Yeah, I think Lemlem, you're frozen, or maybe we lost her too.
I think we might have just lost.
Yeah.
Let me send her a quick message here. All right, everyone. Let's see if Lemlem is going to hop back on. I just sent her a message. I think this is one of the known challenges, right, with the global collaborators is sometimes our connectivity doesn't always come through for us. So we'll wait just a second and see if she is able to connect back in. Does anyone have any questions or events they want to share with the group?
You already did the upcoming Coffee and Conversations, correct?
I think Michelle also froze. So yes, Megan, Michelle started with that. Some upcoming announcements. But yeah, we do have Abdulaziz next week.
And Nar, who's on the call.
Yes, and Nar the week after, yes. And Abdulaziz is here too.
Yeah, maybe Abdulaziz and Nar can say hello and just briefly say something about their topic to interest people in the next two.
Okay. Nar, would you want to start?
Oh, okay. Hi everyone. I'm Nar from Thailand. So I'm gonna talk a little bit more. I feel like I'm still in the show. I'm gonna talk a little bit about the NCD in Thailand and also how people get access to care, both rural, urban, and also technology and research that have been done in regard of cardiovascular disease prevention and control. And that's it. So stay tuned and see you soon.
Thank you, Naru. Yeah, I'm also Abdulaziz. Next week, I'll be talking to you about sexual reproductive health care accessibility among women with disabilities in Sub-Saharan Africa. Basically, we are going to talk about how disability is conceptualized within our sub-region, the challenges women with disabilities face as far as healthcare accessibility is concerned, the way forward, and then how best we can make them feel part and parcel of our various societies. Yeah, so stay tuned.
Thank you both. Welcome back, Michelle. You're unfrozen.
Thank you. Thank you. We seem to all be having connection issues, regardless of where we're at here. I apologize. So I did send Lemlem a message. I have not heard back from her. Oh, wait, I actually think I see her right now. Lemlem, are you connected back with us? It looks like maybe her audio is still connecting here.
And Michelle, in the meanwhile, I saw I think Fian's hand up. Fian, do you have a question for us?
Sorry about that. I'm back. So sorry.
Yay!
Welcome back, Lemlem.
Yeah, I should off my video because it's raining. The network is a little bit not stable. Yeah.
Okay. We can leave your video off. Let me make sure that you have host capabilities again. Bestie, actually, you'll have to make her co-host because I lost host capabilities when I dropped off myself.
Okay, doing it now.
Thank you. All right, Lemlem, you should be able to share your presentation again.
Not yet. It is still disabled.
Okay.
Yeah, now I can.
There we go. It just took a second. Yep.
Yeah. So sorry about the interruption. So the challenge as any African country, issue of the economic problem of the community to, make them restricted from movement and the feasibility of the pandemic restriction. The strategies are very challenging. It's not applicable, most of them, that shutting universities, doing everything online, and this is not culturally, this is not the thing that we practice most of the time. So reaching out vulnerable population in rural area, communicating public education was an issue. Health system strength is also an issue. We have ICU equipment. We have very limited number of ICU equipment. In the beginning of the COVID-19, we have only 200 functional ventilator in Addis. So you can imagine we have 120 million people. So testing facilities also the other issue. The other huge challenge for Ethiopia as well in Africa is the maize and misconception. And the maize and the misconception is also intensified by social media, makes things very challenging. Like in Ethiopian context, like washing with holy water, washing the hand with holy water can you see prevent COVID-19, and people, regardless of the restriction made by the government, people went to holy water to wash their hand, and drinking lemon water, and drinking garlic, eating garlic, drinking this hotty, spicy food will prevent, and that makes people to, I mean, looking for that and unexpected increment in the price of this specific herbs was one of the huge challenge, in addition to the capacity of the health service to support or to respond for the virus. But regardless of this challenge, we have a grand lesson from COVID-19 pandemic. One is as much as possible revising, rebuilding, re-innovating the health system, especially the emergency, the pre-hospital care, the ambulance service was tremendously supported, tremendously strengthened for the future response to any pandemic. Do you hear me, please? Yes? Do you hear me? Well,
yes, we can hear you.
The other opportunity is home-growing production. As I have mentioned earlier, we have a serious scarcity resource like protecting materials. People, young people tries to manufacture from locally available thing, and the students in the university trying to manufacture the ventilator using locally available. So that is also the other grand lesson we have. The other opportunity is delay in pandemic surge. Give us preparation time, global experience, material sharing from developed country, awareness, collaboration, and will be one of the opportunity we have. And learning a new way of life. That means Ethiopian population live together, and there is a lots of gather. People don't hear any kind of restriction. They might be surprised if you say like don't greet hungry people. They say no, we better die than just not greeting people without hugging. So and even using online for teaching, for education purposes in the university and primary school is another new way for us to live. So in general, as it has been said by our health minister, Dr. Lia Taddese, COVID-19 has pushed us to the limit, but it also has demonstrated the importance of preparedness to respond efficiently to health emergencies. This is especially for African countries. It is an opportunity for us to make it a resilient healthcare delivery system, especially for emergency, and it helps us to unified and teamwork, collaboration is also the other opportunity we get. And thank you for listening. I can entertain any questions.
Thank you so much, Lemlem. I'm not sure how Michelle's connectivity is doing. There you are.
am back, but I am also having issues with connectivity, so I may drop off. I think Megan's ready to take the ball if I do. Thank you so much, Lemlem, for joining us and for this excellent presentation. I miss Ethiopian coffee and coffee ceremonies. I love seeing these pictures. And I guess we want to open it up to questions, so please feel free to either raise your hand or put questions in the chat. We'd love to have this be a conversation similar to some of our other
conversations, as I tag team with Michelle. So if you have a question, please just unmute and ask it. Or if you're feeling shy and don't want to interrupt someone, you can raise your hand or type it. I'll start off. Lemlem, you mentioned that one of the things that, oh, I see Abdul has a question actually. So Abdul, go right ahead. And then Narcisa.
All right. Thank you, Lemlem, for the great presentation. I really enjoyed it. My question has to do with perceptions about the COVID-19 vaccine and then the current attitude towards the preventive measures. In Ghana, for instance, a lot of people are of the opinion that the COVID-19 vaccine is a substandard version that was sent to Africa. Others are also of the opinion that now COVID-19 is no more. So they don't see the need for them to go for the vaccine. And even with the wearing of nose mask or face mask, it is now totally off in Ghana. I want to know how these things are also playing out in your country. Thank you.
Thank you. Thank you for asking. And I think the same scenario happened in Ethiopia. The people used to say like, this is a drug sent from other country to reduce the number of African population. So we are not interested to take the vaccine. So even health professionals, for instance, the hospital I'm working, it is a tertiary hospital. Lots of specialties are there. So even nurses and physicians working in the emergency were not interested to take it. So leave alone the community. The community was in complete denial in the first few months of the vaccine initiation. So, but later on, through community mobilization, through approaching of the religious leaders, especially, things is better. Still, the denial is there, but it's better than before. But if you see the number, the complete vaccination rate is increasing. Still, the government is working on that. Still, we are doing the vaccination, vaccine awareness creation in the rural community as well. But these days it is better. But the thing you mentioned is also applies for Ethiopia as well.
Thank you.
Narcisa, do you want to go ahead and ask your question?
Hi, good morning, Lemlem. Thank you for a wonderful presentation. I don't know if you saw my comment, but I said go Eagle. I'm also an Emory Eagle, class of 2005. But what I found one of your slides was very shocking is that the emergency services, there isn't anything in place prior to 2009. So what services were available if you needed emergency care?
Yeah, okay, thank you very much for a very important question. Are you saying these days or prior to 2019? I mean, before the beginning of emergency medicine. These days, we do everything. We do for pre-hospital and hospital emergency service. We do triage services there, all this medical emergency service, and also surgical emergency, pediatrics, and all emergency services are happening both in hospital and out of hospital. Even though it is in a younger stage, it still needs to the government needs to work on it and it is not that much decentralized in the regions, this organized kind of emergency service, pre-hospital and in-hospital service, but it is better after the COVID-19 pandemic, but still we need to work. But before the establishment of the emergency medicine, there was no emergency service. There is no room at all. It's not part of the healthcare. It is not one of the major area like outpatient. For instance, there are services in the hospital, right? So emergency service was non-existent, nothing, even in the capital city. But it starts because of the Millennium Development, the Ethiopian Millennium. It is in relation with that, the development initiated in Ethiopia. If I answer your question, probably I can, yeah.
So what other questions do people have? I have one, just, do you think that if the vaccine had been available more quickly, would there have been less time for distrust and suspicion to arise? So say if the big wave of COVID had hit and the vaccine was immediately available, would that have made a difference?
Probably yes, but still, because the vaccine, the first vaccine started in developed countries like the US, so they have a suspicion. Even people think that the vaccines they are taking in other country might not similar with the one coming to Africa, even in the first place. So probably I feel like it might worse if it comes first. People will not take it.
Oh yeah, no, if it came first, I think people's feeling would be, you all are just experimenting on us, right?
Yeah. That's
because that there's some precedent. Yeah.
Yeah. Probably I don't know. Maybe better.
And
but
just
still, people are not changing their mind on the measures related with COVID vaccination.
Just to add to what Lemlem has explained, I think generally our part of the world, there has been a huge problem with acceptability of vaccines. The general notion is that it is one of the means to control our population. And then I worked on a project that was the malaria vaccine. And it got to a point that some were even attributing it to the fact that they want to introduce the vaccine to control fertility. Others were also of the opinion that if indeed the vaccines are good, why are they not doing the clinical trials in maybe the advanced countries, but rather bringing it to our part of the world? So those issues has been one of the key challenges with the rollout of vaccines in our part of the world.
Thank you both.
I have a question. This is Michelle. I'm afraid to show my video because I keep dropping. But thank you, Lemlem. My question, and I guess it's kind of a request for more conversation as well. But as you know, I've traveled to the northern part of Ethiopia and some of the rural communities, and recognize that many people are far distances from health centers, and that it is difficult to get supplies and health education to some of those individuals in rural regions. And I'm wondering if you've seen any other kind of innovations or innovative ways of reaching the population in those more difficult to reach areas. I personally think that's something we haven't done very well in high income countries. I think, community health workers that I've seen in sub-Saharan Africa have really made connections with communities and sometimes have been able to get information and resources out in a different way than our health systems are set up, at least here in the United States. So I don't know if you have anything else to share or even know quite as much about what's happening in those rural regions. But I'd love to hear a little bit more about how that population is being reached for resources and health education. Lemlem, do we still have you connected? Uh-oh, I think we may have lost her, didn't we, Beste?
We did, yes. I became the host again.
Okay. Well, if anyone else has anything to share on that topic, that's something I've been thinking about. And I think we've talked about a little in the course is this idea of, global collaboration and learning. And I think there have been a lot of innovations during COVID-19 that haven't necessarily been shared beyond kind of like individual health systems or even regions. Aziz, did you have something?
I would want to say something about the innovations we have adopted in Ghana. Initially, there's this concept called home visits. That home visit is usually adopted by community health nurses. So they are mostly stationed in the communities. So when the resistance of the COVID-19 vaccine was so high, what they adopted was that they moved to the various houses and then added it as part of their community education. So now the acceptance is a bit okay. And the remote areas that people don't really have access to healthcare and then health information to, they've made it a point to do what they call outreaches. So they always get motorbikes and then they get their vaccines in their vaccine storage bins and other things to be able to reach out to these people. But there's one other controversy. Initially, when the vaccine was introduced, they exempted pregnant women. But now they are saying that pregnant women can also take up the vaccine. Most of them are also now hesitant because there's some sort of miscommunication. Initially, when you introduced it, you said pregnant women were exempted. But you are now saying that they are also part of it. So which is which? That has been one of the controversies in my country for now. Yeah, basically about that.
When we are waiting for Lemlem, I have some services that from Thailand I would like to share. We do have what we call the people's health system. When we have healthcare volunteer, lay person would be trained from healthcare personnel and then help out with primary screening. At first, it is mainly for NCD and also for infectious disease control, for example, hemolytic fever. But when COVID-19 has epidemic, then we also use health volunteer to work with primary care setting. So our health volunteer primary care setting and also with School of Nursing depends on which part of the catchment area. We work together to do delivery vaccine, especially to bedridden people, and also we do screening. We went out to do outreach for people who would want to maybe get more information about the disease, and at the same time, if they want to get vaccine. So we have that in the system, and at the same time, because of the demand for services regarding to COVID-19 is very high, then we stop seeing NCD patient at the hospital. So we have the healthcare volunteer go to the families and then do home visit and use some kind of telecommunication with healthcare personnel. So the health worker would also, with the lay health personnel, would deliver medication for NCD to the patient at home. So we use that as a screening for patients who just have real need to see healthcare worker or doctors, and it helps a lot.
I think very nice experience, but in Ethiopia, what we did is one of the opportunity we have, one of the grand lesson we have is community mobilization through Red Cross Society. Not healthcare providers, because we don't have that kind of saturated healthcare providers in the country. But what we did is we mobilized volunteers, which is not that common in the country. Through Red Cross Society, we call up volunteers, students, could be university students, to mobilize in the community. But in our healthcare system, there are frontline workers, health extension agents. We mobilized in the community. This normal healthcare system, these people work majorly the maternal and child health care, like advising the community with family planning, to vaccinate their children. But during COVID-19 response, we try to switch them to go to the community level to screen and give education and awareness. Coming to the Michelle question, is there any innovation for reaching the communities in the rural area? Thanks to Ethio Telecom, gladly our society has majority has a mobile phone. So what the government did is the ringing for their mobile is a message of COVID-19, like hand washing, those public preventive strategies always ring to their mobile. So that was one of the criteria, one of the strategy to reach the rural community. So mobile phone is everywhere these days. So that is one of the strategy. And then frontliners, deploying volunteers, and secondary school teachers to the community to teach. Thank you.
Thank you, everybody, for sharing. I appreciate that. Was a really comprehensive answer and gave us a chance to think about many settings. So thank you, everyone. Any other questions for Lemlem? Lemlem, I have one other question for you, which I guess is more of a personal interest, just because I've known you for a few years now and seen you kind of taking this pathway from nursing to research and kind of different areas of focus. And I'm just wondering what your next steps are as a nursing researcher, kind of what you see as critical questions to address related to healthcare in Ethiopia.
Yeah, thank you very much. This is one of my questions as well. Anyway, the plan is this time after master's degree in nursing, if you have the PhD and above, there is no specific area to work on. I mean, it is the individual that decide where to go. So my interest is on research, especially cardiovascular emergency. This time I have applied for the post of Dean's of School of Nursing at AAU. I have applied, hopefully will be successful. And also I have coordinating the PhD program. It was my question for you guys, because I love School of Michigan, School of Nursing. It is close to my heart to work in collaboration. So we have PhD students working in maternal and child health. Their dissertation is on maternal health, reproductive health, especially one of the killer for maternal health, the preeclampsia. So I want to collaborate if I get this position to this university, which I love, really love, and it is one of the springboard for me. This school. So this is my plan, and I love research. I recently applied for another grant to NIH with my mentor from Emory, and also my mentor, my lovely mentor, mother, everything from your School of Nursing, Dr. Sue Anbe. So yeah, these are many very nice, kind-hearted people from School of Nursing, Michigan. So that is my career plan.
Well, we will be keeping our hopes for you on the new position. And just a funny coincidence, I'm finishing my PhD in epidemiology, Lemlem, and my focus is on links between hypertensive disorders in pregnancy and risk for cardiovascular disease and stroke later in life. So we should talk offline at some point.
Please. Yeah, I will. Yeah, thank you. Congratulations.
Oh, thank you. You can congratulate me in December if I finish.
Oh, okay. You will.
I would say when Megan finishes in December, we can congratulate her. And Lemlem, I will definitely follow up because I think there is the potential for some good collaboration with research for our PhD students and kind of evidence-based projects for our DNP students as well.
Oh,
and then I also wanted to let you know, I reached out to Sue Ann and reminded her you were speaking this morning, and she is speaking at a FEMA conference, or I guess it's a meeting in Idaho today, so she couldn't join, but she sent her best wishes.
Yeah, she informed me that I know she's not attending my presentation. Yeah, we are very closely communicating. Thank you so much.
Yes, and thank you. I'll give one more chance. Any last minute questions or comments for Lemlem?
Well, that was a great, it was a great presentation, and I loved the discussion at the end. And I think for all of us thinking about how we keep the pieces of community mobilizations that did work and leverage them for other issues and other crises, but also just sort of keep those connections going, right? How do we keep people who volunteered during COVID motivated to stay connected to public health and to responses to crises, and not just lean on volunteers with nothing going back to them either, because I think at some point that's not so sustainable.
Sure. Yeah.
I think it's helpful to share these experiences too. I appreciate this forum as an opportunity to hear about what's happening in many different settings and types of health systems, because I think we can all learn and take lessons back to wherever we're researching or working or providing clinical care. So go ahead, Beza.
Before you thank everyone, I wanted to say, Lemlem, excellent presentation, and it's so nice to reconnect with you. But I did want to say how striking the numbers were too, because in Ethiopia, I didn't realize how large the population was. It's 1/3 of the United States, pretty much. But then your numbers were in the thousands in terms of death toll. So there's definitely something to learn, right? Some things to learn probably. So I thought it was a striking response from Ethiopia, and thank you for bringing this up to our attention. It's incredible.
Yeah, thank you, Beza, to see you in person here, almost. Thank you. Okay, yeah, I think the number is minimal relatively, but there are a number of hypotheses, not only in Ethiopia, even in Africa. But the hypothesis needs to be, evidence-based. But there are hypotheses why the number is low. They are thinking the population is very young. As you see, only 3% is greater than 65 years. And the altitude and the food, and this is kind of hypothesis that is raised to be the death rate is very low as compared to 120 million people. Probably the issue of registry, vital registry, like this, might not be that meticulous, like developed country, like US. Probably there are people who are not registered as it is. That might be the reason why the number is very low, but it's not that much, frankly speaking.
Well, thank you again, Lemlem. Thank you everyone for hanging on. I know we had some more kind of technical issues today than we have, but I think that's part of this. And I appreciate everybody hanging on, sharing your experiences along the way and joining us. Please join us again next week at the same time. So 8 a.m. Eastern on Tuesday, June 14th. And Aziz Seydu will be talking about reproductive health and disabilities in Ghana. And we look forward to seeing you all then. Have a great day. Bye, everyone. Thank you, Lemlem.